Okay, so we are once again open. We'll continue from where we left the last time. If none of us here has any question, then we'll carry on with something small on hypovolemic shock. Okay, we know we have lots of the shocks, different types of shocks. But we're looking at hypovolemic shock over here and something small about it with respect to test spacing and the rest. Let's look at what we have here. Hypovolemic shock occurs when blood volume decrease through hemorrhage or movement of fluid from intravascular compartment into interstitial space, which is the third space. So we have various ways through which one can get hypovolemic shock. And over here we are saying through hemorrhaging, as in direct bleeding from a severe blood, especially an artery or a major vein, whichever. So as long as you are oozing out, you are decreasing your blood volume, okay, which eventually will lead to hypovolemic shock. Or when the blood volume within your intravascular space, that is within your vessels, become decreased. What happens is that, especially through movement of fluid from intravascular space to interstitial space, or sometimes interstitium is being used instead of interstitial space, okay? And the same as third spacing. Let me try and see if I can demonstrate something small to you here. So let's say you have your normal blood vessel. Pick this one as a normal blood vessels. You have cells, okay, which are closely packed. We have blood vessels within tissues and the rest all over. Okay, for demonstration, I just want to show you this. So there can be instances where fluid will move. The blood is made up of the plasma content, which is the water part, okay? The liquids. Then we have the cellular part too. So in this case, you're looking at the plasma aspect, okay? In this case, we are looking at the plasma aspect, which is the um, watery part. So you can have a situation whereby fluid within the intravascular space as part of blood, okay, will shift and move into tissues, okay? So the spaces in between blood cells, or let's say tissues, spaces in between tissues, that is what we call interstitial spaces or third spaces. So think of edema. When you have edema, it's similarly what happens, okay? When you have edema, ascites, any form of swelling. So that's how it happens. That's why mostly among people with situations like that, you tend to find out that they have low plasma proteins. That's albumin. Their albumin levels will definitely be low. Okay, so we have a condition we call hypoalbuminemia. Okay. So I don't know whether any of you here can relate. Most people with ascites, those um third spacing issues, okay, they tend to have this hypoalbuminemia thing that we're talking about. So most of the times we tend to, depend on the severity of the situation, we encourage them to increase high protein diets. Okay. Sometimes too, especially if it's severe, we can even prescribe human albumin for them. IV, okay, as a form of drug. And sometimes we give them these FFPs, fresh frozen plasma, okay, which all helps to build up intravascular protein plasma or something like that. So through oncotic pressure, when the proteins within the blood or within the intravascular space become higher, then it will tend to pull or to draw water from the interstitial spaces into the intravascular spaces. Okay, and in one way or the other, help to reduce the edema. So generally, pulmonary edema, no, think of wherever the edema is happening from. This oncotic pressure can help do something better. Okay, so just to let you know, hypovolemic shock, you don't get hypovolemic shock only from, you can't get hypovolemic shock only from hemorrhaging, okay? So let us kindly take note. So when someone has, to end this one, when someone has ascites, or someone has something like an ASACA, which is generalized edema, ask yourself, all those fluids sitting in the interstitial spaces, where is that fluid coming from? It's actually from the blood, okay, or from the intravascular space. So that's what it means. Now, the next one, treatment involves preventing additional fluid loss, okay, that is one. Then restoring volume through IV fluids. Then improving hemodynamic stability through vasoactive medications like norepinephrine, which is same as noradrenaline, right? Dopamine, dobutamine, and the rest. Okay. All right. So that is what we have here. And mind you, the kind of fluids you give in this situation is very, very important. Okay, we have uh, two main types. Okay, there might be other types, but two main. When it comes to fluid resuscitation, we have crystalloids, we have colloids. But I think we normally use the crystalloids the more. So atomic solutions, isotonic in terms of the crystalloids that we normally use in resuscitation. To give an example of hypertonic solution, we can mention dextrose 5%, the 10% in the rest. Then isotonic solutions, we have the ringer lactate, normal saline. When we just say normal saline, we mean the 0.9. Okay, we have 0.45 normal saline too. So that is more of hypotonic. So let's take note of that. All right. And we have another type, which is the dextrose 5% in water. So this one, when it's outside the body, it is actually isotonic solution. Okay, 5% dextrose. When it's outside the body, it's isotonic solution. But as soon as it is being transfused or it gets into your body, it now becomes hypotonic solution because the free sugar or the free dextrose or sugar is the same thing. Is being absorbed by the body very quickly, and you are left with only water sitting within your vessels. Okay, so that is the explanation with respect to 5% dextrose. Now, when we talk about these vasoactive medications that help improve blood pressures, when someone has hypovolemic shock, with respect to their vital signs, heart rates will go up. Then blood pressures will go down. So if you want to maintain good blood pressures and mean arterial pressure, what you should do is to restore your fluid first. Then if restoring your fluid doesn't prove good or it proves futile, then you can consider adding inotropic supports like these vasoactive medications you are talking about, the norepinephrine or noradrenaline, okay, dopamine, and the rest. If you have any question on this slide, you can let us know so that we can help you. Any question? Okay, if no question, then we carry on. Okay, norepinephrine causes vasoconstriction and improves heart contractility and output, but effects end quickly. So it should be tapered slowly and cautiously to avoid progression or relapse of shock. So when you have hypovolemic shock or hypovolemia, first thing to do is to give fluids. If the fluids prove futile, then you add your inotropes or vasopressors. Okay. And when, I mean, just in case you start with your norepinephrine or inotropes and you won't stop, let's say you are getting in pressure and you want to stop the inotropic support, what you have to do is to taper the medication down gradually. Okay, you don't stop abruptly because when you stop them abruptly, you end up causing a rebound effect. It's like you're going to have a sharp decrease in blood pressures again in the rest. So you'll have to take your time. And so let's say if you started with, I'm just giving an example here. Let's say you prepared something 15 mils, let's say DNS or NS, and you started at 5 mils per hour. If you want to taper it down, depending on the blood pressures you are having, come down maybe by 0.5 or maybe by 1. Then you taper it down gradually until it is finally stopped. Okay. Now, with respect to the resuscitation fluids too, like I said before, 0.5, 0.45% normal saline. I mean, that is half, okay? 0.45 is half of the 0.9. That's why you have this thing here. Okay, so it's a hypotonic fluid, which is not ideal for treatment of what? Hypovolemic shock. So you rather use 9 or mineral lactate, which helps to increase 0.45 hypertonic dehydration in situations like this. Okay, where you have excessive perspiration too and the rest. If you have any question on this one, you can let us know so that we carry on. Any question? Okay, let's see another thing here. So I think we have a continuation of it. We're saying oxygen, you have to give oxygen to, okay, via face mask used to treat, which is used to treat tissue oxygenation deficiency during shock. You know, when you are in shock, you don't have enough oxygen. I mean, oxygenated blood. When I say oxygen, what I mean is oxygenated blood. You don't have enough of them reaching the, various vital organs. Okay, and those organs will need oxygen definitely. So, as a supportive mechanism, what you should do is to give oxygen so that the little blood that you have available or in circulation, you can enrich them with higher oxygen to help supply oxygen to tissues. So that is why you need oxygen. Then, um, when you give too much oxygen at a point in time, like I always say, oxygen is a drug. So at a point in time, patients will have to be weaned off. So if you started with, let's say, a face mask, you will have to taper it down per the flow rate until you reach nasal prongs flow rate. Then finally, you can wean patients off oxygen. Okay. So looking at everything we've gone through right now, what we employ when you are dealing with hypovolemic shock. All right. First of all, you assess your situation. You give your IV fluids, which is more of isotonic fluids. And if it's fine, then you are good to go. If not, you add your vasopressors or inotropes, okay? You add them to be able to get good blood pressures and mean arterial pressures. You supplement with oxygen, okay? So, just in case you get a selector that apply questions and they ask you which interventions will be necessary in the treatment of hypovolemic shock. I think you can easily picture the idea now, right? So that is the purpose of what we've just gone through. Let's look at another thing, if no question.
Please, I have a question.
Okay.
Sorry, I don't know whether it was everybody, but I kept on going back and forth. My network, I don't know. Yeah. So I have heard what you said now, and I'm just kind of wondering that in what circumstances would we add the vasopressors? Would we add the vasopressors to, the treatment of hypovolemic shock?
Okay. So
Yeah.
like I said, whenever you have let's say you have low blood pressures in hypovolemic shock, you don't just go ahead with vasopressors or let's say inotropes being your first line.
Yeah.
Blood volume is not enough. Okay, in this case, the person has bled or the person has lost water. So what do you think is necessary more over here to replace the fluid which has been lost? Okay,
Yeah.
so you do that first. And if blood pressures do not appreciate, you support with the inotropes we are talking about. So every one of them has a mechanism of action. Okay. Um, no, no adrenaline or no epinephrine. Think will have a constrictive effect on the blood vessels itself. Some will force, I don't know whether it's dopamine or the vitamin. One of them will contract the heart itself. Okay, and having some minimal effect too, constrictive effect too on the blood vessels. So depending on whatever is happening and the patient's medical history too, because there are some of the conditions you can't use some, depending on what is happening. An example is, let's say, people with renal issues. It is better to use, I think, the vitamin also, okay, something like that, or dopamine, like one of them, depending on what is really happening. Okay, so what I want us to take right here with respect to all this is that make sure it doesn't become your first line. Your first line is please, then you support. Then when you've achieved your optimal blood pressures and mean arterial pressures, then you can decide to wean
Sorry,
patients
sir.
off.
Please, sorry to interrupt. Please, I didn't hear the first one, the first treatment, please. Can you repeat that for me, please? I'm writing this, please. Sorry.
So I said you have hypovolemic shock. So what you're supposed to treat first is your IV fluids, isotonic fluids. Okay. Then if after
Okay, thank you.
using your isotonic fluids, blood pressures, mean arterial pressures do not become better, then you can add up your inotropic support until you achieve your targeted mean arterial pressures and blood pressures. Then later, you can wean patients off the inotropes. Then, like we just spoke about, you can add oxygen to help support. Peter Christie, your highness, sir.
Okay, boss, thank you. The continuation, we need that. I saw antibiotics should never be postponed in septic shock. So, in septic shock too, that means that you have to give IV fluid first before antibiotics, right? Oh,
Oh, okay. So, fine. So our concentration was more on hypovolemic shock. So, like I said earlier, we have different types of shock. Okay. So let's say in septic shock like this, there are lots of things which happens in septic shock. One, um, you see, one important thing that normally happens in septic shock is blood vessel dilation. We have various mechanisms through which that happens, not even only one. Okay, but whatever happens in septic shock, you have blood vessels dilated. So that is more of what normally end them having, end up like for them having this low blood pressures. It's like you have, let me demonstrate something over here so that we can understand. Although septic shock is different, but let's say you have 100 mils. I'm just using this as a demonstration. You have 100 mils passing through this cell. I mean, this is the normal for it, okay? So you have 100 mils of blood passing through this vessel, and this is the normal. And for that matter, you have normal blood pressures and vital signs in this situation. Now, situation becomes different, okay? Or, I mean, situation changes, and you now have the blood vessel to be like this instead of this. But you still have the same amount of fluid or blood passing through this same vessel. Just a demonstration for you to understand what normally happens in septic shock. Do you think the person will be able to hold blood pressures in the wrist? And we have toxins. We have to one way that this vasodilation normally occurs in septic shock is because of the toxins. So toxins have an effect of causing vasodilation, and you have to have low blood volume with respect to or compared to um, the vessel volume or the vessel size. So patients would definitely have low blood pressures in this case. And sepsis is infection. All right. So in septic shock, you are having a severe form of infection, which has even ended up in giving you shock. So what do you do in this case? You should never postpone antibiotics because you see, when it comes to the management in septic shock you give your IV fluids. That becomes your immediate one, but septic shock will still be there if not treated with antibiotics. The cause of the low blood pressures in septic shock is because of toxin effects or, bacteria effects, whichever. So to be able to deal with the situation permanently, you will have to give an appropriate antibiotic as you treat your hypovolemia in septic shock. Please, do you understand what I'm trying to present to you? Are you following? The one who has the question? Or the person is not here anymore? Okay, but the rest, please, do you understand what I'm trying to say? Can you hear me too?
Yes.
Yes, we understand.
Let's
All
continue.
right.
Yes.
So let's look at another thing, if no question. Let's look at extubation management. Extubation management. So after we intubate a patient and we've put the patient on a mechanical ventilator. The last time I showed you a picture of how it looks like. When the person has recovered from whatever thing we wanted to treat, what you will have to do is to prepare the patient for extubation, which simply means removing the tube from the patient's throat, okay? Like removing the endotracheal tube. So some things or some measures you have to put in place. You don't just go ahead and extubate patients. So let's look at how we manage extubation. So recently extubated patients are at higher risk for aspiration, okay, airway obstruction, and respiratory distress. So one thing is, the endotracheal tube, when I say ET tube, it's the same as endotracheal tube, okay? So the ET tube in the patient's throat, it's a foreign material. And most patients tend to fight it a lot. And because the foreign material over there, especially during the intubation process, sometimes tissues around are being traumatized. Okay, and because naturally the tube is not supposed to be there, but it's just put in there temporarily to help patients. When we extubate, what normally happens is sometimes you get laryngeal edema or even spasms around the airway where the tube was inside down there. And for some patients, just few minutes after extubation, you will hear some stridor. Okay, their breath. You feel. When we say stridor, that's sh I don't know whether we are more conversant with that sound. When an asthmatic patient is having a crisis, I think most of us have witnessed that before. Sometimes there's some stridor, okay? So you hear difficulty breathing here, and you hear that stridor or stridor, depending on how you pronounce it. So that should tell you that the patient is having laryngeal edema. And for that matter, that means we still have to protect the airway and re-intubate, okay? So that's why you have to prepare for all of these before you even try to extubate. And as soon as you extubate, you monitor patients very, very well for these things: laryngeal edema, spasms, and the respiratory distress and the rest, so that you can intervene. Remember, the respiratory system or your airway won't wait for you when there is an issue, okay? It won't wait for you, so you have to be on guard to help prevent or to help solve situations like this should they arise. So the second point here, we are saying to prevent complications, patients are placed in high fowless position to maximize lung expansion and to prevent aspiration. Okay, so position is very, very, very important. Remember, I think this is like a generalized NCLEX idea or NCLEX knowledge. If you have a patient who has respiratory issues, or let's say respiratory distress, and you are supposed to manage these patients, should you get this question anywhere? And among the options, you have something like elevate head end of bed. Mostly that becomes your first answer. Okay. You don't just rush in to do some invasive things and the rest. Sometimes just position. I mean, you start from the little things before you go to the more higher things, okay, or the invasive areas. So it is the same for this patient too. You will have to keep this patient in high Fowler's position to help maximize the lung and prevent aspiration too. And of course, after extubation, you will have to give oxygen. So most of the times, depending on the protocol, it mostly started with the non-rebreather. Okay. We start with non-rebreather. If patient does well, then we bring it back to simple face mask. Then we can finally do the nasal prongs. Then wean patient off. Okay. So what we are saying here is that the oxygen should be warmed and humidified. Okay. And it should be administered to patients immediately after extubation to provide high concentrations of supplemental oxygen without drying the mucus. So that means if the oxygen you are providing is not humidified and warmed, this is what will happen. You have patient mucous membranes becoming dry. And when it becomes severe, it can be, it can bleed. Okay, when it becomes severe, you can have cracks within the mucous linings and cause bleeding. Then we are also saying oral care. Remember, we were doing oral care for patients when the patient was intubated on mechanical ventilator, right? How frequently should we do oral care when patient is intubated on a ventilator? How frequent? Who can
Two
help us?
hours.
Mm-hmm.
2 hourly.
Too early. Okay, so some will say 2 to 4, but too early is ideal to decrease risk of. Remember, in everything I asked you for rationale. So I've started it nicely for you to decrease the risk of what?
Infection, oral infection.
Oral infection. Is it oral infection? Ventilator associated.
And then
The
ventilator
aspiration.
acquired pneumonia.
VAP.
Yes.
Yeah.
VAP. Okay.
Ventilator
Uh-huh.
acquired pneumonia.
Yes.
Associated. Yeah.
Okay. So that is the reason. Okay.
Which one is the reason?
Hey,
Because
you
a
didn't
lot
say
has
that.
been said.
So ventilator associated pneumonia
Okay.
or acquired pneumonia.
Uh,
Okay.
okay.
All right. Now let's look at here. We are saying oral care provided to decrease bacteria and promote comfort. Patients is instructed to cough frequently, and deep breathing exercise is also encouraged. The use of incentive spirometer, okay, is also encouraged. It helps a lot. It helps to expand the alveoli and recreate more alveoli, okay, to help in breathing. And for that matter, helps prevent lung collapse, which is atelectasis here. The last point, we are saying patients should be kept MPO after extubation to prevent aspiration. and have either a bedside swallow screen or a formal swallow evaluation by a speech therapist prior to swallowing any food, drink, or medication. So right after extubation, you have to be very careful if you want to resume feeding, or if you want patient to take anything by mouth, you have to do swallowing test. So depending on whichever question you get, the specialist who is supposed to take care of this is the speech therapist, okay? So depending on the options that you have, if speech therapist is there, they are more better in doing this. Of course, we can also do all cases. What we are saying is that do not give anything by mouth until you have assessed for swallowing test, or you've done swallowing screen, or you've evaluated the patient's ability to swallow without any risk of aspiration. Any question on this one? Any question? Okay, so let's carry on. So you see, we are still hitting on some important areas all over. Now let's look at another thing here. Suctioning and blood draws for patients on ventilators. We will definitely treat arterial blood as, okay, ABGs in live class. But I think we can talk about something small, not too deep, but we will see how we will go about this one. But it will be treated fully, okay? What this slide is trying to tell us is that a patient who is on a ventilator, we are trying to present a situation here. You have a patient on ventilator, and this patient is being suctioned from time to time, like PRN, okay? That's when necessary. But we still have to get blood draws, okay, from this patient for tests like arterial blood gases. There are questions on this one. So let's look at what we should take note over here. ABGs indicate acid-base balance in body and oxygen carrying capacity. So arterial blood gases, as the name even implies, the amount or percentage of gases within your artery, within your arterial blood, okay? So it helps us when someone is on ventilator, frequent ABGs can help us even determine whether we should switch patients into a particular mode or maybe a different mode or whichever. Okay, depending on what you get. So let's say you've done one ABG, patient is showing, let's say ABG value. Forget about the, please, if you don't understand, don't worry, we'll do it proper. Okay. Let's say patient is having a pH of, let's say, 7.12. This is more acidotic. Okay. So let's say it's metabolic, or if it's respiratory, too, fine. What can you do to help this patient who is on ventilator? What you can do in this case with respect to ventilator settings is to increase the respiratory rate, okay, or the respiration rate on the ventilator so that the patient can breathe more and expel more carbon dioxide. Carbon dioxide is an acidic gas. So the more you hyperventilate, then the more you blow away or you blow out CO2. And that in a way can help decrease or let's say increase your pH. As pH increase, you go into alkalinity, okay, so to help resolve the issue. So that is why it's very important to understand why something is done, or especially ABGs. I mean, the importance of it on a patient who is being ventilated. It helps a lot. Okay. So let's look at what we have here on our slide. We're saying ABGs indicate acid-base balance in the body and oxygen carrying capacity. ABGs are measured. I think there's D here. So ABGs are measured after a ventilator change to assess how well the patient tolerated it. Okay. So patient condition can influence mood that we should put patients on. Then after patient has been on that mode for some time, we can do a repeat ABG to see how well the patient is tolerating that mode. Okay. So factors such as changes in patient activity level or oxygen settings or suctioning 20 minutes prior to blood draw can cause inaccurate results. So let's say I'm about to do ABGs for a patient and this patient is intubated. Let's say I suction the patient right now. And in the next 5 minutes, I go in, then redraw blood sample for ABG. What this slide is telling us, or is trying to tell us, is that we are likely to get inaccurate results. Because you know that whenever you are suctioning the patient, do you know that you pull or you withdraw some oxygen from the patient? I mean, for a period. Okay. That is why you should hyperventilate, or let's say hyperoxygenate. You should hyperoxygenate. So that's the ideal word. Okay. So before you suction the patient, this one is general, whether you are about to take a sample for ABGs or not. Before you suction the patient and the trachea tube, you should hyperoxygenate. There is a button on the ventilator which is used for that. So most modern ventilators will give you up to 2 minutes of hyper oxygenation time. Okay, that is not too necessary here though, but what is more important is don't forget that you pre-oxygenate. Okay, pre-oxygenation, hyperoxygenation, you see any of them. So what we mean is that you hyperoxygenate or pre-oxygenate patients before. And what will happen is that, you see, you've loaded, by doing that, you load patients with a certain amount or level of oxygen for that time. So that at least when you are suctioning, you know that you are pulling away some oxygen too. So that oxygen overload you've given already when you were pre-oxygenating will take care of the one that you are withdrawing through suctioning. Okay. So that is the rationale behind the pre-oxygenation too, or hypoxygenation. All right. So pre-oxygenation should occur prior to suctioning and before position changes. So you see, we said higher activity level, and so whatever thing you engage patients or you allow patients to do, oxygen is bent. Mhm. You use oxygen to you come to 10 patients. I mean, anything that increases patients' activity level, you should also pre-oxygenate patients so that patients can have enough oxygen for that purpose. Okay. Any question at this time before we continue?
Okay, I have a question to ask, please. Hello.
Please, can you hear me?
Yes, I can hear you, please. Can you also hear me?
I can hear you loud and clear.
Okay, so I'm asking, you were talking about when you want to take the sample for ABG for somebody who has recently been extubated. I want to ask, how many minutes should you wait to check for the ABG after the person has been extubated?
After the person has been extubated, is that your question?
Yes, and then you want to take a sample for ABG. How many minutes should you wait?
Okay, so
Yeah, Ima,
for
let me
for
take this
this,
question.
hello,
Yeah,
were you saying something?
yeah, Ima.
I can hear you. Can you hear me?
Yeah, yeah. With regards to the ABG's question she's asking, please, can you hear me? I don't know if I can
Yeah, you can
continue.
continue. We all hear you.
Yes, please, we can.
All right. So, let me start from the fact that if someone is on oxygen, okay, and the person can tolerate weaning of oxygen before taking the blood sample for ABGs, it should be 30 minutes. All right. If only the person can tolerate it. But if the person can't tolerate it, then you should take the sample as it is, as the person is on oxygen. But when the results are out, let the physician be aware, okay, because definitely it's going to alter the results. Okay, so from this idea that I want to chip in that if the person is extubated, definitely it's going to affect the person's oxygen one way or the other. Okay. Well, modernization, there can be some machines, modern machines that can help with the interpretation in the correct way. But for now, I think you have to let the patient also be aware of the condition surrounding how you took the sample so that they can also intervene accordingly. All right. So that's what I would like to say with regards to your question. I don't know if it helps. Thank you.
Okay, thank you.
Okay, thank you for that. So mostly right after extubation, it depends. You don't always dwell on if this should be done. I think that wouldn't be immediate. Okay. Um, we've learned something, I think, from 20 minutes after. When you want to know, is it 20? No, I think
They said
it
30
doesn't.
minutes.
20, come again.
I thought boss said 30 minutes. You have to, even if you have to do it, you have to wait till after 30 minutes.
Yes. So anywhere from
30
20 minutes
minutes.
going and above. Okay. So 20, 30, it could even be 1 hour, unless emergency. So it's like we don't have anyone waiting. But it wouldn't make any sense for you to extubate patients and immediately take samples for ABGs, unless maybe emergency something has happened. Okay, so it's like you allow time for whatever thing that you've done. So between 20 to 30 minutes or even more, sometimes you can allow patients to even be on oxygen for some time before. So it depends. But there is no, but one thing is it shouldn't be immediate. So that is most important thing. It shouldn't be immediate. But anywhere from 20 to 30 minutes and even up to 1 hour, it's fine. Or even more, depending on the person's physiological situation. But in most cases, do you know that even after, if only unless the patient has a metabolic situation, okay, or let's say, let me give you an example. If the person is, let's say, having diabetes, we are treating this patient um, of, let's say, a condition like diabetes ketoacidosis. even after extubation, we will have to do repeat ABGs from time to time. So it depends, okay? And for some patients, after extubation, we will not even, I mean, there will even be no need for ABGs. I think we have some critical care nurses who can be improved to that. There are some patients, they only needed maybe some few mechanical ventilatory support after you've done your ABG swires on them, and I mean you've done everything and you've extubated them successfully. Mostly, they will not even need another one unless their medical condition or the underlying condition demands for it. So it is not like a one way forward. Please, you understand what we are saying? It's not like a one way thing like that.
Hello.
Yeah, this is Rosemary.
Yes, I wanted to make a contribution that
Okay.
for example in the ICU, taking an ABG sample, the baseline or the reason for it is to correct electrolytes in your gases. So it is not like, as you said, that okay, it's just after 30 minutes that I have to do. It's like part of the procedures you have to do. So assuming you took the first ABG, let's say 30 minutes after extubation, probably patient went through cardiac surgery and all that. And then you found out that, oh, you corrected your gases or your electrolytes. At least you want to see an improvement on the patient's condition. So thereafter, you may want to wait maybe, oh, 1 hour, let me still do my next ABG to find out if I'm in line. Probably if I'm in acidosis, I'll correct. If I'm in alkalosis, I know what to do. If I need to correct electrolytes, potassium and all that, then you keep doing it until you realize that, oh, patient is stable, electrolytes are becoming normal and all that. So it's not a one-time thing. It's continuous, depending on the patient's case, for you to ensure patients become stable. Thank you.
Thank you for that addition. So that's what you are saying. Thank you for adding those things. So it's not like we have a strict time, okay? Every situation and every diagnosis will come with, and even with the same diagnosis, it might be different for different patients. Let's say you have 4 patients with the same condition. Some will require more than, I mean, the other. Okay, so it's not like a one-way thing. So what is happening is what you decide on, and I mean, know what to do for the patient, how many times you should do, and the rest. All right, thank you. Any other question, contribution?
I'm sure something small to ask. We are not talking about it, but if I help you to I want to know the difference between intubation and ventilation. Is there any difference? Intubation and
Intubation and
ventilation.
ventilation.
Yes, is there a difference?
Okay, intubation,
Oh.
in, tube, Asian. Can you hear those sounds? Those sounds, can you hear them? In,
So that means there is
then tube.
a tube.
Oh, that's good. I don't know whether it's from her end or my end. Okay. The rest of you, can you hear me?
Yes.
Yes, please.
But I think it's from her end. So intubation, like in, tube, then Asian. So it's like you're putting
So please,
in
that means
an endotracheal tube, okay, into the patient's trachea, okay, through the mouth. We even have nasotrachea, okay. That one too, you have a tube that will end up in your trachea, but through your nose. When I say your nose, I mean your nostrils. So you have a endotracheal tube, you have a nasotracheal tube, depending on what you are saying and what you mean. Okay, so that is intubation, when you are putting in the tube, intubation. And extubation is when you are removing it. Ventilation is like breathing. Generally, when you say ventilation, it is like you are breathing. So right now, as we are in right now, we are all ventilating. Okay. we are taking in oxygen, we are bringing out CO2 and other gases. But one thing is, with respect to ventilators, when you say ventilation, then the ventilator is doing this inspiration and expiration for you. So when we say ventilation, maybe you are ventilating patients or patients on a ventilator, this breathing in and breathing out, you've given the work to a mechanical ventilator to do it for you. Please, have I answered that question?
Yes, please. Thank you very much. And please, can somebody be on intubation and at the same time on ventilation?
Come again with the question.
Like, can somebody be intubated and at the same time be on ventilation?
Oh, of course, when you're intubated, you should be on a ventilator. Otherwise, it's like, okay, so okay, you let me count down small. You see,
Emma, can you draw something or show a picture of it? I think
okay,
those in the
okay, let
ICU will see this clearly. But then if you can see a picture of it.
uh, let me say that. Oh, it's more practical, especially where we want to find ourselves. Let me see. Okay, let me just type intubation with patients. Okay, so look at this one. So the process of putting in this endotracheal tube, okay? So like I said, we have one. So this is the process of doing it. Okay. In it. So after let's say we've put the tube in, okay, we've intubated patients. Ask yourself, why are we even intubating patients? We are intubating patients because patients will need ventilatory support. And what we mean by ventilatory support is the person cannot breathe in and breathe out like normally, as everybody should breathe, because of maybe an underlying condition or what is really happening. Okay, so that is even the reason for even putting this tube in there. Remember, when you're going in for surgery, especially a surgery that will require general anesthesia, the reason for intubating you, I don't know if anyone here has gone through general anesthesia before. Anyone who has gone through general anesthesia, mostly you have been
Yes,
intubated.
yes.
Okay. Yes. So ask yourself, why are you intubated? Have you asked yourself this question? Because we paralyze you, your whole body, everything, your respiratory muscles, everything will be paralyzed. Because we want to knock you off. Then we can get chance to perform the procedure. So we intubate you so that we can take control over your airway and your ventilation. So we intubate you, then we connect this one to the, in this case, inside the theater room. We connect this one to an easier machine. I mean, it has a ventilator part and all those things. Connect it to the machine. And the anesthetists will be doing your monitorings and everything. So because we've knocked you, we've put you under general anesthesia, we want to take care of your respiration, I mean your breathing. So that's why we put in this tube there. But remember, it's not only surgeries that can render you in this situation. Sometimes medical conditions or surgical conditions, any condition can render you in this situation. And for that matter, we should equally take control or take over your respiration and treat you for some time until you can do your own breathing.
My senior girl.
Okay. So we put in this there. You can't put in this there and leave the patient like that. When you put in this there, you have to either you ambu back, but you can't ambu back for forever. Okay. So what you do, so that's where the mechanical ventilator comes in. So you intubate, then you connect the tube and let me see whether I can get a better picture here. So mechanical ventilator, I think this is an example of it. Okay, the machine here is a mechanical ventilator. So you see the circuit. The last time I showed you circuits of a ventilator in our first lesson. So you see this
So,
person, this is
so
a
that
filter.
you
Uh-huh.
assess first when there is a beep.
Come
or something.
again.
So that's why we assess the patient first when there is a beep or something. Low.
So you will set the PEEP. For everybody walking normally, like you and I walking right now, you see the ventilator functions like our physiological system, how our lungs function. Do you know that generally especially adults, like everybody is walking with a PEEP of 5, generally. Okay. So most of the times when you can ask maybe the critical care nurses, they can confirm. So most of the times when we intubate patients, unless the patient has a lung issue. Let me give you an example. A patient with ARDS, acute respiratory distress syndrome, you can never give a PEEP of 5 because the lungs are collapsed.
Low
You would
peak.
have to give a high PEEP, then reduced, if you're doing volumes, I'll not go there, but I mean, if you understand what I'm saying, you reduce tidal volume. I mean, the amount of air or the volume of air that is going to the lungs, you reduce it, but you give higher PEEPs to prevent barotrauma. You give higher PEEPs because when you give higher PEEPs and you give higher volumes, you end up blowing the lungs up. Okay, barotrauma. So you don't want that. When one goes up, the other has to come down a bit. Okay. But in situations like ARDS, you want the pressures to take the effect. So you give lower tidal volumes. Then you give high PEEPs so that you can end up opening the alveoli for the gaseous exchange you want to happen. Okay. But if, let's say, there are not special cases and it's just normal intubation, you just want to take control over the patient's airway for some time, what you will have to do is to, I mean, most of the times between 5, 6, 7 PEEPs, but most of the times 5, which is like everybody's normal PEEP that, I mean, he or she is ventilating with. Okay. So, back to your question, and to make your question short, or the answer to your question short, when you intubate patients, you connect patients to a mechanical ventilator so that the mechanical ventilator can do the breathing for the patients. If you don't, it gets to a time and you don't need the tube there, what it means is that, of course, before you don't need the tube there, it means patients should be able to breathe, I mean, by him or herself. We have ventilator modes where you will have to also taper down before you know whether patient is breathing. But the ventilator modes and the rest, the NCLEX is not important, so I'll not go there plenty. I'm just mentioning them. Okay, before you win patients off ventilator, you step down the modes. Okay. Uh-huh. So when you come to a mode where patient will be doing the breathing by him or herself, then what it means is that we have to prepare to remove the tube. We have situations where patients will not be able to will not do well with extubation for some time. Let's say they will have to continue with mechanical ventilatory support for sometimes even more than a month, 2 months, and more. So for these patients, we have other measures which are put in place for them. You will not want to do endotracheal intubation, or you will not want to keep the tube in there for all this while. Most of the times, you prepare them for tracheostomy.
Okay.
Okay.
Yeah.
Most of the times after 14 days or so. Yeah, you prepare them for tracheostomy. Then you remove the tube because the tube also, it harbors infections, respiratory infections, and the rest. I mean, it has its own complications. So most of the times after 14 days, maximum of 14 days, you just remove it. You prepare for tracheostomy tube to take over the airway. And most of the time they do well with the tracheostomy. Okay. But it doesn't make sense if patients will only spend 1 week, just in case patients will spend 1 week on a ventilator. You don't have to go straight for uh tracheostomy. That is why these measures are in place. Please do you understand the whole thing, what you're talking about.
Yes, please. Thank you very much.
You're welcome. Any other question? Okay. So NCLEX is making us become critical care nurses gradually, right? So let's carry on. All right. I think there's something here at the last part. So if patient is being weaned from ventilator, sedation is reduced. Of course, most of the times within the first 24 hours to 48 hours, as soon as you intubate patient, okay, you will have to sedate patients to be on the ventilator for some time because they tend to fight the ventilator a lot. Sometimes they'll be wondering, sorry, sometimes they'll be wondering what is happening and, you know, they will not understand, okay? And they will tend to fight the ventilator. It's very common. So most of the times we sedate them for some time. Then at, let's say after 24 to 48 hours, we wean them off, then orient them for assessments and everything. You orient them. If they are compliant, then maybe you can hold your sedation. Or if even the need be, that one too, it depends on the person's condition. So everything or every medical condition which is happening, you can't say there is one way thing. It always depends on the condition and what is currently happening. So there is no one way thing. Okay. All right. So before you prepare to remove, sorry, before you prepare to remove an endotracheal tube from patients, you have to make sure that the sedation is reduced and I mean everything is fine before. Please, let's take this question. Someone should read it for us, please.
The peak pressure alarm is sounding on the ventilator of the client. With a recent tracheostomy, what intervention should be done first? A. Assess the client's respiratory status. B. Decrease the sensitivity of the alarm. C. Ensure that the connecting tubing is not kinked. And D. Suction the client.
Who wants to try?
Well, I'll go for A.
Can you give us your reason for choosing it?
I chose A because I'll have to assess the patient first to know what is going on before I do any other thing.
Okay, thank you very much. Anyone with different answer?
I will also go for A because
Uh-huh.
the last time you said when the alarm beats, is that the ventilator, meaning there's a problem, it's not working, meaning the client is not able to get the assistance from the ventilator. So with that, the respiration level will be what affected. So you have to first check, is the client breathing? If it's not breathing, then you now check what is the cause of the client not breathing. Is it that the tubes are kinked or the connection is loose? So I
Very
think that
good. You remember what we talked about the last time? Very good. Okay, so to keep it straight, the answer is truly A. Okay. Remember, whatever thing that is happening to a patient on a mechanical ventilator, whenever you are with this patient and situations like this happen, you have to check on the patient first. We said it, right? You check on the patient first before you check on the machine. So you assess the client's respiratory status. So that becomes the answer. Well done. Okay. So that's the rationale. If you want to go through quickly, can. Okay, let's look at the next one. Can someone take it for us? Mhm. Hey, no one wants to read it. Okay, let me read my thing. The nurse is supervising a nursing student who will suction a patient on a mechanical ventilator. Which actions indicate that the student has a correct understanding of this procedure? Select all that apply. Who understands the question before we even look at the options? What are we looking at for?
Let me try. Let me try. We are
Okay,
looking at the techniques involved in doing proper sectioning.
okay. So it means whichever option that you choose should be a correct one, right?
Yes.
So with the select order, let's do it together. The
So
first
one,
one, read it for us.
the student nurse uses a sterile catheter and glove. And then
Okay,
three,
so let's consider that one first before.
okay,
We are doing this together, okay? So do
okay.
we think it's part of the answer? Should we use sterile glove
Yes.
Yes,
and sterile catheter? Of course, yes.
yes, please.
Okay, so that is for endotracheal suctioning, right? What
Yes.
about if we are doing oral suctioning? Should we use sterile catheter and sterile glove?
Yes.
You can use the catheter, but you don't use the sterile gloves.
Good. So the mouth is not sterile. Okay. The mouth is not sterile. Your respiratory tract, lower respiratory tract is sterile, but your mouth is not sterile. So with oral suctioning, that is why when it comes to delegation of task among UAP, RN, and LPN, the UAP can do oral suctioning. I hope you're aware.
Yes.
You remember UAPs cannot do sterile procedures, and for that matter, they cannot perform sterile suctioning, but they can perform oral suctioning. So take note, some of the things, they are just related. When you know the concept, you can relate elsewhere, okay? So the first one, okay, this one, you have to choose the answers. It's like I'm choosing for you. So let's do,
Simon,
yeah,
listen, let me ask a question about the UAP performing oral section. So
okay.
if oral care. So if this client is on mechanical ventilator, can the UAP do oral care?
No.
So,
So I saw a question like that the UAPs cannot manage such a case.
yeah. So you see,
Mm.
when a patient is on mechanical ventilator, especially the picture I showed you,
No.
you have the tube inside the mouth. Should you allow the UAP who is not trained to handle the
No.
situation to do? No.
No.
So the oral action we are talking about is not the mouth of
Basically,
intubated patient, okay? Just a normal patient. But with someone intubated, please don't go anywhere around you if you are UAP. Please, are you okay?
I'm okay, but it looks a bit, it's mouth care, I understand. But oral section, and most of the time, these people that we do oral section for are unconscious people and all that.
So if
So
the
that
patient is unconscious and not intubated, this one is like a rule.
mm-mm.
This is like a
so
rule.
it's just like normal mouth care, right?
Yes.
Come again. Yeah,
Okay.
yeah. So it's like normal mouth care for the UAP.
Okay.
Okay.
All right.
For UAP. But if the person has a tube, like a endotracheal tube, don't allow the UAP. The UAP should not go around the mouth.
Yes.
Okay. Because the tube is in the mouth. And doing oral care, look at this practically. Doing oral care, if you don't take care, you pull the tube out, or the tube will even be dislodged. The UAP is not going to do that.
Can I come in? Because if
Yes,
I could
Becca.
remember, they said the duties of the UAP, you don't let them attend to clients who are not stable. You only let them attend to clients who are stable clients. So if you keep that in mind, I don't think a client who is under intubation, you should even dare let a UAP attend to that client.
Okay,
Because the
good.
client
So
is
that's
not
also another
stable.
way.
It's
Good.
not client.
Very good. Please, are you clear now? Our
Yes.
sister who has the
Thank,
question.
thank you. Thank you.
You're welcome.
Okay.
So it's a law, okay? Whether it's like whether you understand or you don't, it is a law. It's like do not steal. Okay. So whether you love stealing or not, you shouldn't steal. So that's how it is. Okay, so let us all solve the option 2 before. And sorry, let us consider it and see. I don't want to be choosing answers for you. So kindly participate and let's go. Okay. Kindly read it for us. Our sister was reading. Oh, someone was
So
reading.
the students should I continue with the answers or I should start all over?
Yes, please.
Okay.
No, the 2. We picked the 1, right?
Okay, so the student nurse applies suction while inserting the catheter.
Is that correct?
No.
So what is the right thing to do here? Anyone
So
at all can
whilst you are coming out, that is where you have to apply your suction. So
Good,
we may take 3.
good. So when you are about to suction, when you are inserting your suction catheter into the endotracheal tube, okay, consider the suction catheter to be like an NG tube. It's slender, okay, like like this. So let's say if this is your tube, okay, when you are inserting the suction catheter, so this one connected to your suction machine. When you are inserting the suction catheter into the endotracheal tube, you don't apply suction. But when you reach down there, you withdraw. I mean, you go until you meet resistance. When you are in, after you draw about 1 centimeter to prevent um mucosal lining damage. Okay, so you withdraw about 1 centimeter, then you start applying your suction in the swelling motion as you come out. So that's how it's been done. Okay. Oh, I've added another option. I've answered
4.
another option. Oh, okay. No problem. Let's carry on. So the student nurse applies action whilst inserting the tube. Correct or wrong?
Wrong. It's wrong.
Let's move on to 3.
Correct.
Oh, who is reading?
The 3 is correct. We've chosen it already. So that's what you have explained. Then the 4.
Apply
The student
suction during catheter. Okay. All right. Catheter removal. Okay. What about 4?
The student nurse uses a twirling motion when withdrawing the catheter. Also correct.
Correct.
The student nurse uses a number 12 French catheter.
Okay. So this one, it depends.
Yes.
The size is very dicey. Okay. I know.
Voice.
The size will depend on the size of the endotracheal tube, which is in situ. Okay, the type of catheter you should use. But mostly between 12 for adults, between 12 or 14. Okay, I think the 12 is a white one. Then the 14 is green also, something like this. And the 16 is, color coding is orange also, something like that. Okay, so mostly between 12 and 14. That's the ideal. Okay. All right.
The student must apply suction for at least 20 seconds. Wrong.
Is it true or not true?
5 to 10 seconds.
Correct or wrong?
Wrong.
Some people don't have the vim to say wrong. They are just
Wrong.
hiding behind other voices. Be bold and be courageous. Do
Yeah.
not
Wrong.
fear the Lord.
Wrong.
Okay.
Wrong.
So, of course, the student next apply section 4. So what's the ideal wait time?
10 to 15
Less
seconds.
than 10 seconds.
Shouldn't be more than
Less
10. Okay.
10
So
seconds.
maximum of 10. Okay. That's the ideal, maximum of 10 seconds. So whenever you disconnect a patient's tube to suction, you are supposed to perform all of this within 10 seconds. Then you connect patient back to ventilator. All right. The answers are 1, 3, 4, 5. So you can see 1, 3, 4, 5. Last one is no parts. Okay. So you're correct. So you can see here, apply suction for no more than 10 seconds to minimize hypoxemia during suction. So you see it's even here, 12 or 14 French size suction catheters. So like I was saying. All right. Look at this one. Let's talk about another thing here. How to visualize the airway. Okay, and while maintaining neutral alignment in case of head or back spinal injury. So this one is about how to maintain a patent airway when you have a spinal injury, especially upper back, okay, or a head injury. It is very important. At a point in time, I think we will do ethics and ethical principles. We have lots of things to say over there. But in the meantime, let's go by what we have here. Now, legal situations involving trauma should follow your EBC route. Okay. We have CEB. Okay, we have CEB2, which starts with circulation, airway, then breathing. But CAB should only be encouraged in cardiac resuscitation. Okay. When you are doing cardiac resuscitation, that is where your CEB should apply. But when you are doing normal prioritization, like asking prioritization questions, and you get a question involving normal clinical situations concerning trauma and the rest, that one you have to follow your ABC. So take note, those are the differences. Now, the
Please
second point, come again.
Yes, please.
I didn't hear what you said.
What you said, please.
You said I should repeat what I said. So what I'm saying is when you are performing cardiac resuscitation, you should follow your CAB principle. C for circulation, A for airway, then B for breathing. That means if you have airway compromise and you have circulation issue in CPR or cardiac resuscitation, the C comes first before A, then B will follow. Okay, so it is like CAP in cardiac resuscitation, but you follow your ABC in normal prioritization questions and trauma situations like what we are about to go through. Please, do you get what I just said?
Yes, please. Thank you.
You're welcome. So the next point we are saying airway assessment is particularly clients with injuries to the head, to the neck, and to the upper back. Very, very critical. Injury to the upper back should be treated as spinal trauma until the client has been cleared by an advanced trauma life support qualified healthcare provider. So until that aspect has been ruled out, treat it as spinal trauma. So you ask yourself, how do you handle airway in someone with spinal trauma? So until the spine is appropriately assessed, the client should be placed on a backboard and stabilized. So backboard, sometimes you see something like hard surface. Backboard, of course, has a hard surface. So sometimes you might get a situation where they will tell you put the patient on maybe a flat hard surface, straight and stabilized. It is the same as backboard. I mean, something just stabilized. I mean, a hard surface to stabilize the patient. So that's what we mean over here. Then this is the key word here. When you have spinal injuries and you want to take care of the airway, this is the key word. You have to use the jaw thrust. Please, this one, okay, maybe to show you pictures so that you see how it is. We have the chin lift, head tilt, okay? We have that one there. Then we have jaw thrust also there. They are very different. Don't go and do head tilts. Which you're doing the person more harm than good. Okay, so take note of this one well. If you want to open up patient airway to help open it up or control it, someone who has a spinal injury, especially upper back, this is what you must do, not head tilt. Then avoid movement of an unstable spine. Okay, I mean, you do this so that you avoid movements of an unstable spine. That's what you're saying here. So one provider should stabilize, I'll show you this very soon. One provider should stabilize the cervical vertebrae, your cervical vertebrae, allowing the second provider to articulate the jaw. So you need two people to do this jaw thrust successfully. So the nurse should use the jaw thrust to maneuver the jaw thrust maneuver to avoid any further injuries. So look at the last point here. I repeat it here again. One provider should stabilize the cervical vertebra, allowing the second provider to articulate the jaw independently of the spinal column. Let me see if I can show you something here. Where is it? Jaw thrusting, jaw thrust maneuver. Have you seen the pictures? You see how it's done? So you keep the head straight and everything. So that's how you do the jaw thrust. So look at this one. You shift the head. Um, hmm, uh, let me see how I can even describe it to you. I think this is a nice way of doing it. This one. So you hold the jaw, each jaw at each end, okay, as this person has done, okay, by the bridge over here, okay, sorry, by the edges over here. Then you push it up, okay. It's a jaw thrust. You see the direction. You push it up, and you open the person's mouth. So it's like when you push it up, the occiput will come a bit down. Then for the neck to be straightened. So when you do that, in like real life situation, you see the neck very straight or almost straightened. Okay. Whilst the mouth is open, the throat is open, then you have the airway protected, and air can easily move in. So you don't do the head tilt. So you see, look over. I think this one, the direction is shown here. So that's how you do the jaw to open up the airway. Okay. So one person must do this. Okay. Then the other person too can help with other things. So you can see. All right. Jaw thrust. All right. If you have any question, you can ask. If not, we continue.
Sorry, I have a little, like, I'm a bit confused. Can you go over not really go over, but C,
This time I'm coming in. Zara, please, you can
CAB,
continue.
you talked about a CAB, like, I think I went off, so I didn't understand. You said when it's the spinal cord injury, you should do circulation first. Is that what you're saying?
So what we said is that when you have a spinal injury or upper back injury, you should do the jaw thrust instead of head tilt and the rest.
I don't think
Do
I
you get it
understand.
now?
You talked about when you want to answer a question. You talked
Your
about
voice is a bit
when
low. Can you come again?
you talked about when you want to answer a question, you should start with the circulation first.
So I was saying, in cardiac resuscitation, you follow CAB instead of ABC. That was what I said. But in normal prioritization question and like trauma situations like what we are going through, you should use your ABC. So that was what I said previously. Please, are you okay?
Yeah,
Okay.
thank you.
You're welcome. Sister Eva, you can ask your question.
Okay, so with the movements of a patient with the unstable spine, can you please use the log growth to where the patient is being like moved or transferred as a unit?
Yeah, so yes, yes, of course. So that helps to keep the back straight. Okay. So you don't carry the person like one at the head part and one at the foot part. That will destabilize your straightness. Okay. So yes, that is very good and it's applicable. Is that, are you okay?
Yes, please. Thank you.
You're welcome. Please, any other question? Okay, so I think we can continue. Sorry. So we have another thing to talk about here when it comes to feeding. Okay. when it comes to feeding a patient. All right. Let me say what I have to say. Then after we look at what we have on the slide. So when it comes to feeding a patient, especially someone who is critically ill, especially in the ICU, generally we prefer continuous feeding than bolus feeding. The main reason is to prevent risk of what? Aspiration. So that's the whole idea in a nutshell. Okay. Bolus feeding is where, let me give you an instance. The dietitian or a healthcare provider will prescribe foods like maybe 200 mils of ensure 4 hourly, okay, or 300 mils of ensure 4 hourly. When the 4 hours is up, what you have to do is to go in there, even though you do your assessment, you do your assessment like your gastric residual volume, you check your bowel sounds, tube placement, and all of that. You know, things that you're supposed to do before you push in food into patients' NG tube or gastrostomy tube, whichever. You do all of that before you begin feeding. But when the time or the due time is up for you to feed, what happens is after doing your checks, around that time, that quantified or prescribed amounts will be poured in the patient's stomach, okay, all at once. So that is bolus feeding. Continual feeding is where you have a pump, okay, connected to a feed hanging, like you are giving an IV fluid. Then it's connected to an NG tube. Then you can set a feed value, okay, a flow rate of, let's say, depending on what you want to give, maybe 20 mils per hour or something like that, depending on what you want to achieve. That one, to let me show you quickly before we even start this one. Some of us get it all in picture. It's when um you see the pictures, right? Let me check this one. Okay, so let's use this one. So please look at this one. So look at this one. You see the patient has an NG tube in here. This is the feed, the enteral feed. It's connected to a pump, okay, an infusion pump with a set flow rate connected to the NG tube. So the feed will be going in small, bit by bit, okay? And with this one, gastric empty is very fast because let's say within an hour, you have about 20 mils of food going in. It means it's going to move your body or is than pushing people at once. So what people in the critical care unit, mostly the continual feeding helps a lot than the bolus feeding. So this is through an NG tube. Then this is through a gastrostomy tube. So you see where this one, the tube is the baby. So whichever. So these are continuous feeding. So this is what we want to talk about. Okay. All right. Now let's go back to our slide. So critical ill patients are at increased risk for aspiration of oropharyngeal secretions and gastric content. So it is common in intubated patients, ventilated patients, and patients who are on mechanical ventilator receiving enteral feedings. This greatly increases when receiving bolus rather than continual enteral feeding. Bolus feedings are avoided in critical ill patients who are already at increased risk for aspiration. You know, when the patient is critically ill, we should have let's say we should care more about their nutrition very well, because muscle wasting and lots of
The whole Ghana not a
malnutrition issues, lots of malnutrition issues can happen when people are critically ill. Okay, so it's very, very important to take care of patient nutritional needs. So let's say if a patient has an increased risk for aspiration, we can say because of that the patient should not eat at all. But at least what we can do to help is to put the patient on continual enteral feeds, and that will help prevent, in a way, prevent the risk of aspiration or reduce the risk of aspiration. What we are saying over here too is assessing gastric residual volumes every 4 hours is a standard when receiving continual enteral feeds. So just in case you are receiving this continual enteral feeds, you also have to check residual volumes every 4 hours. Increased volumes indicate poor absorption. So when you check and you have increased volume, so you compare the amount you've given within the 4 hours that you're going to check, and you find out that all what you've given or the set flow rates, when you total them, okay, or you add them up to the 4 hours, they are almost the same as, I mean, what you find in the stomach as gastric residual volume is the same as what has gone, and it means patient is not absorbing the food. Okay. And for that matter, even with continual feeding, when that happens or continues for some time, patients can still aspirate. Okay. When that happens, patients can still aspirate. So that is why there's a need for us to do every 4 hours residual volume check. Over here, we are saying measuring the number of centimeters at nest. So I mean, this one talks about tube placement confirmation. Okay, at a point in time, you will have to check for tube placement too, especially when you are doing your gastric residual volume check. You do it together with that. So it's like every 4 hours too. Okay. But before you even use a newly placed Menji tube, you'll have to confirm with an X-ray before you use it. Okay. And just in case it has displaced and you've readjusted, you also have to make sure that it is in. So how do you confirm? How do you confirm without doubt? It is only when the X-ray tells you or X-ray picks it within the esophagus, that is where you can have a justification. Okay, when you have the tip in your stomach, that's where you have a justification. Any question about this part? If no question, then we talk about chest tube drainage systems.
Yes, I
Mr.
now have a
James,
question. Yes.
you can ask your question.
Yes, what I want to know is that with the continuous feeding, is it like giving the infusion continuously, or there's a specific time that
Exactly.
we
But this time,
do?
yeah, is it my network or her network? But
Hello.
are you done with your question?
Yeah, so I just want to know the difference. Is it do we give it continuously, or for instance, it's 4 hours, 4 hours has come, and then we set it on a specific time, like next 30 minutes or 1 hour, that it is completed and then we discontinue
Okay. So it is continuously.
continuously.
Yes. So you see, you ask yourself this question. With the bolus, at a point in time, do we stop?
The
Are you
bolus?
appreciating it? Yes. At a point in time, do we stop the bolus?
No, we give it
Pa-
timely.
Yes. But patients will have to feed every day, isn't it?
Yes.
Yes. So that is also what happens in the continuous feeding.
So what I
Okay.
mean is that we
Every
don't hold
24
it.
hours.
So once one it is completed, then we set another one on.
Yes, like that.
Okay.
Mostly, for it depends on protocols, but mostly the bag is changed every 24 hours.
Okay.
Mostly, especially, but sometimes protocols might differ, but it's ideal to change the bag. Sometimes some of them are washable, some
Okay.
of them too, you will have to. It depends on the preparation. Sometimes the preparation comes in pack, so as soon as it's up, you throw it away, you fix a new one. Okay. So we have different types of people. Do you have any dietitian here?
Hello.
They are expert in that. Yes.
Hello.
Yes, sister.
Please, so the continuous feed you are explaining, can we say that TPN is a type of the continuous feed?
TPN. Please continue feeding that. The feeding thing that we're talking about enteral phase, not parenteral phase.
Oh, okay.
Okay. Yes. So enteral phase was what we're talking about. The TPNs are very expensive, and
Yes.
out than to depend on TPN. So understand that there's a situation where that's why we are considering TPN for you for a particular time.
Mm.
Okay, but ideally, that is why let me give you a corresponding example. Do you know that when patient becomes a bit stable and patient can swallow, most of the times most healthcare providers would want to switch all IV medications to oral liberal intake.
Mm.
Have you realized that?
Yes.
Yes, because taking things through the normal route increases your chance of recovery and everything becomes normal more than going the other way around. It's not ideal for everybody to be receiving IV fluids throughout. It's situational. Your condition has allowed that, and we do that to help you for a short period of time. But how do you generally get water in your body? It is through drinking, isn't it? So it is the same as the eating. How do you normally take in food? It's not through the. So that's the most natural way, and that's what we want. But given the TPN, let's say you have intestinal obstruction or bowel disease, and for that matter, for that period where that condition is happening, you don't want to give you anything through the guts, okay, or through the mouth, so that you can have issues with your guts. So that is when we consider the TPN to help you temporarily. Please, do you appreciate it?
Yes, please. Thank you.
You're welcome. Any other question? All right. If there are no further questions, let's talk about chest drainage systems. Chest drainage systems. In this case, we are talking about chest tubes, right? That's what we have here. Then maybe I can add up later. Gentle, continuous bubbling in the suction control chamber. Okay, this is not supposed to be there. This was supposed to explain a certain diagram. Forget about the section A part here. Okay. Gentle, continuous bubbling in the suction control chamber of a chest tube drainage unit indicates that suction is present and the unit is functioning appropriately. So the nurse should document the finding and continue to monitor. Let me make this one more simple for you. After this class, I'll see whether I can drop a summary of this part on the page, okay? But in the meantime, let me make it a bit simple for you. Let's say we have suction, let me use abbreviation, okay? Control chamber, okay? Or, okay, let me say that. And you have, let's say, only chest tube just mentioned, chest tube. So over here, let me even write the section. I just want to make something clear here. And it is always like that. It's just a trick. Chest tube. So just tube without hearing section. So let me use this one generally as a chest tube, okay? So this part is connected to the, this part goes to the patient, okay? Then there's your chest tube. I'm just making a sketch of something. Underwater sewer drainage. So this is the normal. When it comes to only, like when in question saying, when you get a question and they tell you patient has a chest tube, and a whole lot of additions, said about the question and the rest. And they never mentioned suction. Listen to this part for me. They never mentioned suction. They only mentioned chest tube. They never mentioned suction or suction control chamber, whichever word it is. Suction should not come. Okay. If they just describe the chest tube, the patient is having this chest tube and the rest and the rest without mentioned in the question. This is how the tube should be. For a normal underwater sewer drainage or a chest tube, you should have an intermittent bubbling. Okay. So whenever the patient breathe in and breathe out, okay, you will see a bubbling. Okay, so most of the times, wait, let me see. Is it which one, which cycle helps inflate the lungs or helps close the pleural space? Which breathing mechanism close the pleural space? Remember the chest tube, it sits inside the pleural space, okay? The parts where you have, the parts between your visceral pleura and the parietal pleura. Most of the time, that's where this chest tube sits, okay? So maybe you have a pneumothorax or hemopneumothorax or hemothorax, whichever. Whatever that is, it should not be there, and we have to drain it out. So we will put a tube in there, and there should be intermittent bubbling upon breathing in a normal chest tube. If you see a continuous bubbling, which is not intermittent, intermittent means like it breaks, okay? Like when the patient breathes in one cycle, then it will bubble, then stop, another cycle, then it will bubble again. So that's intermittently. Okay, if you see a continuous bubbling in a normal chest tube compartment, then it means there's an issue with it, either a leakage or a breakage somewhere. So that shouldn't happen. Okay, now the other part is where you have a situation whereby they've told you that the chest tube is connected to a suction wall or a suction control chamber, in which case the word suction has been mentioned. So what do you think in this case? Okay, you see how a suction effect happens. Let's say you want to, I don't even know how to even put it, but suction draws air. Okay, that's what I want to say. Suction draws air. So whenever you have a chest tube connected to a suction control chamber or a suction wall, in which case, like I said before, there's a suction. The normal one is that you should have a continuous bubbling because of the suctioning. So the normal one is that it should have a continuous bubbling for the suction one. And when you see it intermittently, like it comes and it breaks, that means there's an issue with it, with the suctioning one. So it is opposite of the other one. Okay. I'm repeating myself. That sum up the whole of this slide. I'm repeating myself again. When you get chest tube questions and suction is never mentioned in the question, okay, you should have, especially in the chamber, you should have an intermittent bubbling or tidalling. Sometimes that's the word they use, and that is okay for a normal chest tube drainage system without a suction. That means suction has not been mentioned in the question. Okay, and for that matter, should you get a continuous bubbling or continuous tidalling, it's wrong. That means there's a breakage or a leakage in the system. But for suction control chambers, if they tell you patient has chest tube and is connected to a suction wall or suction control chamber, in this case, suction has been mentioned. So what we are saying is that you should have a continuous bubbling in this case, which is it's normal. Okay. And for that matter, when you get intermittent bubbling in such cases, then that means there's something wrong with the system and it has to be checked. So that is all about the chest tube drainage systems that I want you to know. Okay. Now let's look at what we have here too. Subcutaneous emphysema is air that has leaked into tissues. Okay, so like a trap of air under the skin that can be palpated. Okay, you feel that this crepitus sound or crackling sound when you palpate the skin. Okay, this crackling sound when you palpate the skin. So that is subcutaneous emphysema. Okay, you can get situations like that. Sometimes as a complication of chest tube insertion. If it is not inserted well, subcutaneous emphysema, and sometimes it can be severe in a way that it can go throughout the whole body, up to the feet. Okay, at worst. And when palpating the skin, it does not affect bubbling within the chest tube drainage unit. An air leak would cause a leak gauge or water seal chamber, but not in the suction control chamber. So, the summary of everything is what I've told you. Okay. I don't have that modernized one picture here. But in the meantime, if you have any questions before I start asking my questions. Any question?
Hello,
If no
sir.
question, yeah.
So mine
Please.
is not a question. Seriously, I've been struggling with understanding this, and then I want to say thank you for clarifying it. Most of the
Okay.
questions, like I'll select the answer at this point is wrong, and I'm confused. But I think you've made it so simple. Thank you.
You're welcome. You can apply this idea and this trick to all chess tube questions and you see, okay? Very, very easy. Yes, any other question or contribution? Okay, if not, then let's go straight to this question. You are providing care to a patient with chest tube. On assessment of the drainage system, you note continuous bubbling in the water seal chamber and oscillation. So which of the following is the correct nursing intervention for this type of finding? So just apply the trick. Who wants to try?
I'll go for B.
Okay. I also go for D.
Please, I
I
also
also
go
go
for
for
D.
D.
B
D.
should
D
explain.
for
Then
dog.
D for
D
dog.
for dog.
I chose B because I made this simple for me in order for me myself to understand.
D should also
When you
explain.
were talking,
So can you tell?
okay, when you were talking, said with the chest tube, when it's continuous. So I made it CC, chest tube, continuous babbling. And suctioning, I made it CS, suctioning, and what did I even make it? Oh, I've forgotten, but the answer is B. I chose B.
I want you to defend your answer. That's why I'm worrying you. So what from what I said really influenced your B answer, right? Is that what you're saying?
Yes, please.
Hey, madam. Is that Janet?
No,
Okay. Okay,
maybe
so
there's another Janet, I don't know.
all right. Tia, you come in. Then the D people, you can explain yourself.
Hello, sir. Please, I think the answer is D
So why D?
because in the water seal chamber, we are supposed to have intermittent bubbling as normal. So since we have continuous bubbling, that means there's an air leak somewhere. So we have to check the drainage system. And they've not mentioned suction, so we can't say it's normal. So I think the answer is B.
Okay. Okay. So let's check our answer and see. Please read the rationale very well. Our sister who chose B, I think you changed the whole thing. Okay. I think from what I did, I've even made it more simpler, haven't I? Haven't I made it more simpler? Any question? Are we good to go?
Yes.
All right, so let's see. Please ask the question. Let's look at this question too. The patient in room 2569 calls on the call light to tell you something is wrong with his chest tube. When you arrive to the room, you note that the drainage system has fallen on its side and is leaking drainage onto the floor from a crack in the system. So after assessing the situation, what do you think will be your next priority?
Please, I will choose D.
I also choose B.
D for dog.
Yes.
D for
Yes,
dog.
please.
I also choose B.
Anyone with any different option? Okay, so we all agree, right? So that is why it is very important that you keep a sterile water, a bowl of sterile water, beside a patient with chest tube. Okay. So that in case of accidental dislodgement, you dip it into the the bowl of sterile water. Okay. So let's look at this one too. You are assessing a patient who is post-op from chest tube insertion. On assessment, you note there is a 50 ml serosanguinous fluid in the drainage chamber. Fluctuation of water in the water seal chamber when the patient breathes in and out, and bubbling in the suction control chamber. Which of the following is the most appropriate nursing intervention? This question is very, 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 very interesting. Look at it all. Apply everything we've spoken about. I mean, we've spoken about. Who said A? The person should know now. Who said A? Don't hide yourself. This time your hand is up. Was that you? Someone should try for us.
Please, I'll choose A.
I think
Why
it's
A?
I also choose A.
Are you sure it is A? Look at the question well. Are you sure? So, those who are choosing A, explain to me. Are you sure it is A? Explain to me. Let me hear you. A. So, because of what I'm doing and what I'm saying, so you don't want to own up. The A people, after answering, you're hiding. You don't believe in your answer. Eh? Okay. If you don't believe in your answer, that is fine. Hmm. That is fine. So the answer is A. Now, who doesn't understand why the answer is A? I wanted to see whether someone would have changed the answer, but instead of defending it, you didn't defend it. You didn't
You
choose
went
any
to
different
say
answer. You just ran away.
hiding.
So who doesn't understand why the answer is A?
Please, I don't understand because we have in the question taking it from the patient breathe in and out and bubbling in a suction control chamber. So that bubbling, shouldn't it be continuous? Should it be bubbling? That's why I don't get the answer to be A.
So bubbling in the suction control chamber. You see an issue here.
That's the only place I have an issue.
You have
That's the only sentence I don't understand. So I'm not convinced of the A.
of the A. So what did you expect to find here before you think it's suggestive of the A? Let me know your mind so that I'll know where to help you from.
Asamo.
Okay, so the thing is,
Because in the question they brought a suction control chamber, meaning that the system, or when patient breathe in and out, I'm supposed to see a continuous bubbling.
so for you, the continuous is missing here. You only see bubbling.
This bubbling, I don't know whether it's intermittent or continuous. That is my only confusion here. That's the only, maybe I don't understand.
Yeah, I understand you. I understand
Continuous
you.
rest. Mhm.
So
Babbling.
when you say bubbling, bubbling is bubbling. So you take it as like bubbling. If it is intermittent, they will tell you it's intermittent. Okay. So that's also one tricky way. I think this one is even more when someone tells you, like I don't even know where to even relate, but I mean bubbling is bubbling. Okay, though it wasn't specified, but take it as bubbling. I mean there is bubbling in the suction control chamber.
Okay.
Okay, unless
Yeah.
it's intermittent, they will let you know that it's intermittent.
Yeah, Mate. That's why.
All right. Any other question? Where I put this question from a well, I think we have another one here. So you have a patient who is about to have a chest tube removed by the physician. So as the nurse assistant with the over, which of the following actions will you perform? So let's do this one so that apply. Is the first one part. Someone should read it for us, please. Are we tired already? Are we tired?
I didn't hear you very well. The part you said we should read.
Oh yeah, someone should read it for us. The first one.
The whole
I want
question
us to do
or
it
the
together. No, the options. I read the question. though.
oh
I
okay.
said the patient. I said the
Hey,
patient to. Okay, someone should take it up. Yeah.
A,
Patient
educate the patient how to take a deep breath out and inhale rapidly while the tube is being removed.
Do we think this is correct statement?
No.
No.
So what makes it wrong?
Patient should take deep
Rapidly.
and hold it.
All right. So that makes it wrong. Okay, so wait. Before we even look at the options, someone should tell us the right way before we even look at the rest.
It should
How
be
should it be done?
in and out, not out and in.
No, in and out. You know what in and out means. So see
Sorry,
everything. Okay.
sorry.
So I was saying say everything. Don't say in and out. Some people might not understand your
Okay,
in
so
and
the
out.
patient should take a deep breath in
Okay.
and then out. It shouldn't
Okay.
be a deep breath out and inhale rapidly.
Okay. Okay. Thank you. Thank you for
Welcome.
that. So the next one, B. Let's go.
Gather
That's fine.
supplies needed, which will include a petroleum gauze dressing per physician preference.
Do we think it's correct?
Yes.
Do we think it's correct?
No.
Really?
No.
Yeah.
No.
If no, why?
Why,
And if yes, why?
why
What will
petroleum?
Because I've witnessed a chest tube before. I think they always put a dry gauze
It's a
on
dry
it.
gauze, not
Not
petroleum gauze.
petroleum.
Supplies, right?
It will only moist the place, worsen the
you
infection
see,
level.
you see why I'm laughing?
Hey,
Some people are bringing in their what they do on
B
their
is
work.
correct.
B is correct.
And
Okay,
is
so
it added per
what would the
physician
petroleum gauze be
preference?
used for? Someone should answer that. What will it be used for?
Cover the incision site to prevent air leak.
Prevent air leak. Good.
Yeah.
To prevent air leak. So those of you who use dry gauze, it means you didn't have petroleum gauze. So you improvise. Okay, so that doesn't mean
Yeah.
that is the right thing. Okay. So for some people,
Yeah.
for some people they even use this Vaseline. I know it's improvisation, which is not proper. Some people even use Vaseline, then they will smear it on the gauze, then they will use it over there. The petroleum over there will help prevent any air leakage. Okay. Remember that space has a direct connection with your urine. So you don't want any air to be sucked in. To increase your risk of what? Pneumothorax. Let us continue. Option C.
Brima,
Yes, sister.
please, what if you meet an option like a porous dressing? Is it the same as the petroleum gauze
No.
dressing?
Porous. No,
A
porous, they
porous.
have holes inside.
Good.
Air will
Good.
leak. Something that is
Good.
porous, it means that it gives access to air.
Good.
Okay, okay, thank you.
So you should consider non-porous rather, not porous.
Non-porous. Okay.
Yeah.
Miss
Thank you.
Minister Emma, please then
Yeah.
clarify which kind of dressing do we use the porous? Just a quick one.
It depends on the situation. Or maybe I can't think of conditions, but can you give me an example? I think we have different types of dressing where you use porous. You have, I remember those times,
The
but
IV
not
line.
anywhere near these areas. If anyone can remember anything, the person can bring it out. I think we have types of, we have wet,
The
we have
IV
dry
line.
dressing. Well, so please, we have, as for me, what I know, you can read about wound dressing. Those of us who have
I
met it
think
before, I
CS
think you can
dressing.
relate. Yes.
Yeah,
Okay.
patients
That's
who
why
have
I
undergone
remember.
CS.
That is why I remember those wound dressings and the rest, but not around this areas. Maybe we can search on that more. Okay. But when we appreciate the rationale, I think it will make sense. Remember the rationale we just gave. We don't want air to enter into the pleural space. So don't think of anything porous. So that's the rationale. When you understand what you want to do, you can relate and do the right thing. Let's go to option C.
Option C is wrong.
Is my reader sleeping or my reader has vacated?
Option C is wrong.
Place the client in semi-powerless position.
Yes, it's wrong.
Why?
It should be
High foulers.
So if
Is it
it
true?
should be high foulers and you have semi-foulers, do you think it's
You
entirely
still
wrong?
take it.
No.
I'm asking a question. This one, I'm just asking a harmless question. If it should be high foulers and you have semi-foulers in this situation, do you think it's still wrong?
No.
Does it affect patients something like severely?
No.
So should it be part of the answer or not? I'm
It should
asking
be.
you.
It should
Thank
be.
you.
Okay.
It should be part of the answer.
Now the next one. My reader is asleep.
Have the
Right?
patient take a deep breath, exhale, and bear down during removal of the tube.
Do you think it's true?
Yes.
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 What maneuver is this?
Valsalva.
Good. So if you don't see this explanation, and one day you go and see Vasava somewhere, just simple as that. Don't expect to see all these things spelled out before you know it is a correct answer. Okay.
E. Pre-medicate prior to removal as ordered by the physician.
Yes.
So
Yes, it's correct.
which pre-medications mostly?
Analgesia.
Morphine.
Pain, yeah.
Yeah.
Pain medications. The last one, huh?
Place the patient
Okay.
place the patient in prone position after removal.
Is that
Hey.
true?
Yeah.
You're saying
Wrong. Wrong.
No, wrong.
I think it's B,
it's
the
right.
powerless.
Okay, so you are choosing B, C,
B,
D,
C,
right?
D, E.
B, C, D. All right. Let's look at our answer. So we are correct. B, C, D. You see how easy it is? Very, 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 very easy.
Hello,
Let's take
Simon.
maybe our last
But
question.
it added the last one. Oh. The last one that we said no. It said place the patient in a prone position.
No,
And
we
I'm
didn't add.
No, we said high foulers.
okay.
Okay. We said high foulers there, and we said like it's not necessary, at least low semi foulers is also fine. In this case, prone position after removal will not help. Sterling.
Yes, sir. Please, I don't know if it's deliberate, but when you bring out the answers, the rationale doesn't show.
Oh yeah, for this one, the rationale, because we've already discussed the rationales, the rationales
Please,
over
we
here.
need it for revision. I beg.
Oh, okay. But
So it's
well,
not only this one. I think the two previous ones, they all didn't show.
yeah, for chest tube, I think for the
Yes,
last
please.
two questions, yeah.
I will need it. I beg you.
I didn't include it.
Can you include it?
But the rationale, when you play the audio, the rationale is everything we've seen. So you can capture it. Okay.
I
You
want
can
to read.
capture it. You want to read it? Yeah.
Yes, sir. Thank you very much.
So
Brahima,
you
can you go back to the questioning?
if you want to read it after,
Okay.
I don't want to make a promise, but well, just from here, you can message me. Why? I'll see what I can do about it.
Yes, sir. Thank you.
You're welcome. Please, are you okay with the one who said I should come back?
Yes, thank you.
You're welcome. So let's look at this one. The student nurse diligently assesses her patient with a chest tube. She notices that the suction control chamber of the chest tube is not bubbling. What's the first thing this student should do? See one interesting question.
I'll take a B. A patient to cough and the brush check results.
I'll go
Also
for
go for
C.
B.
Tricky, eh?
B.
Someone was going for C, but when the second person chose the B, the person has rescinded.
Yes.
So I'll go for
I'll go
C.
for B.
Choose your answer per your own discretion. What you've picked out of this.
I'll go for C.
What was the answer? Agree. People are afraid.
Please,
The one
I'll
who
go for
chose
C.
C. Oh, you didn't choose your answer early. You've kept quiet for long. You didn't choose your answer early. So you see,
Hey, check the level
yes.
on the wall. Check the level of the pressure on the wall. Hey, I can't find it. Say diligent.
Whenever you are doing a class questionnaire, or if you are here and your time is almost up to go and write the exam, let this thing ring louder in your mind always. Assessment. Whenever you get questions that include assessments in the options here, look at it for whether it can be applicable. most of the times the assessment part is likely to be correct. Okay. Document this as normal. We know that A can be eliminated because it's not normal. Looking at D, you do not clamp a patient chest tube without permission, and even for that, it should not last for how many minutes? Who remembers that? It should not last for how many minutes?
10
Clamping patient
seconds.
chest. 10 seconds. Good. It shouldn't last for more than that. To prevent risk of what? To prevent risk of what?
Tension in pneumothorax.
Good. Okay.
Hypoxemia.
Not hypoxemia in this case. So, encourage the patient to cough and deep breathe and check the level of the suction on the wall. At least the suction control chamber is not bubbling. So in this case, the patient is not actually under any distress or something, but just that the chest tube is not bubbling. So you check the level of the suction, okay, on the wall. So that is the answer. Right. So I think we will end it here and continue from autonomic dysreflexia when we come the next time, then relate it to some issues which are more critical. Thank you for today's session. If you have any question, you can ask.
Thank you too.
Thank
Any
you.
question?
Thank you too, sir. We are grateful.
You're welcome. Any question?